The role of design in electronic health records, past, present, and future. This presentation will try to break the perception that the EHR is a digital data vault, a system that you put data into and that you retrieve data from. The EHR is really a critical tool in the delivery of healthcare, and for this reason, it's far more accurate to think of it as a conductor or a quarterback, as the nervous system or the road network, but not a digital filing cabinet. And associated with this purpose of the EHR, it's important to realize that when we think of its interface or its design, we always need to be thinking of it in relationship to the greater purpose of the healthcare system. And so this is why, as we'll see, EHR design is actually quite related to healthcare system design. And you can't really think about one without thinking of the other. And so today, we'll go through three parts. The first part talks about what is design. We're going to look at how design is how something works. We'll talk about the importance of having a purpose in relationship to a design. And then we'll look at the evolution of the medical record and the changing of what that purpose might have been over time. Second, we'll talk about the state of design and the EHRs today, starting with some subjective data, looking at physician dissatisfaction, looking at some objective data regarding efficiency and safety issues, and then discuss how finally the trouble with EHR design is actually percolating now to the front page and to public recognition. We'll look at some causes for bad design, some areas for better design, and look at some groups working on better EHR innovation. And the third section on the future of EHR design will start by looking at the challenges that were faced in healthcare on a global level. Because, as I mentioned, without understanding the challenges that we face and the potential opportunities, we can't understand what the purpose and the needs of that EHR design are. And so I think we live in a particularly exciting time when you look at the challenges we face and the opportunities that technology present, because the EHR will be a really fundamental component in the future of healthcare systems and healthcare delivery. So let's start at the beginning. What is design? Often we think of design as how something looks. Someone may even use the term aesthetics to be synonymous with design. And you can look online at Wikipedia or for many formal complex definitions of design, but I think the best summary of design is by Steve Jobs, who said, most people make the mistake of thinking design is what it looks like. People think it's the veneer, that designers are handed this box and told, make it look good. That's not what we think design is. It's not just what it looks like and feels like. Design is how it works. And so the big takeaway from this whole presentation really is design is how it works. And this is really regardless of what subspecialty of design discipline you're working in. So in EHRs, we're often thinking about user experience design, visual design, system design, and process design, interaction design. Regardless of the discipline, the overarching theme is how does it work? This means that one of the questions we need to ask ourselves is the design good or bad? The answer to this is really how well does that design solve a problem? And so if we were thinking about this from the perspective of philosophy, we may say that something is good insofar that it achieves its purpose. And so the purpose of a hammer is to hammer nails, and the ability or inability of a hammer to hit nails provides a benchmark in our evaluation if it's a good or a bad hammer. And so then the question is, well, what's the purpose of the electronic health record? What problem does its existence try to solve? And so by knowing the end problem we are solving for, we can evaluate the design of that EHR and its ability to achieve the goal. I mean, it's probably even worth an activity of just pausing the presentation now and taking a step back and wondering, what even is the purpose of the medical record? And I think if you consider this, you'll realize that, well, it really depends who you ask. The administration has very different opinions maybe than finance, which has different opinions than the physicians. And so when you're trying to design a system, a healthcare system, whose purpose do you prioritize? I think if you look over time, you might see that there's been several major milestones in the evolution of the medical record, and each of these milestones brought with it different sub-purposes. I would say that, for many millennia, the medical record was held internally within the patient. Patients would tell their clinician about their symptoms of scrofula or scurvy, or being treated with leeches. And so the first major milestone was the transition from oral history to written records. This probably occurred around the 1900s, and it was generally brought in actually for the purpose of billing and litigation. And so, for instance, in the NHS in the 1940s, we see the need for written records. And so billing and litigation, in many ways, nothing has changed over this time. I'd say the second major milestone was the move from unstructured notes to structured notes. This probably occurred somewhere around the 1970s, and for the large part was the result of having larger care teams around a patient. And so now the chart needed to function also as a tool for communication. Of course, the problem-oriented medical record of the 1970s exemplifies this shift to structured notation, which made team collaboration easier. And now the record could also be used for sub-purposes of auditing and quality assessments. And then we come to the third milestone, which is the move from paper to digital. This is, a process that started in the 1970s and 1980s, but really gained traction more in the 1990s through 2000s. And now EHR systems were being asked to control costs, improve care, produce reports, administer population health, public health, act as a personal health record for the patient, assist in drug and disease surveillance, the list goes on. But the problem was that when the medical record went from paper to digital, in many cases, all that happened was a replication of the paper chart on the computer screen. It had the same tabs and dividers, and in many respects, the reason that this user interface was chosen was just the limitations of computer user interface software available at the time. But we're now 30 years on from that, and very little has changed in terms of the EHR user interface and functionality, despite major changes in technology. And so the replication of the traditional paper record on a digital screen is the results in an EHR that is ill-handled to be able to meet the demands of modern healthcare systems. For instance, if we go back in time to these first written records, you had a single physician looking at the chart. And then in the second milestone, we had multiple care providers needing to work with the chart at once. And all we've done is we've moved this paper chart into a digital format, but in today's context, through task shifting and moving work which was done by a physician to other allied health professionals, we now have hundreds of actors that need to have their work safely coordinated in real time with these clinical systems. And so perhaps I would propose that the fourth milestone, which we need in the evolution of medical records, is to move from viewing it as an electronic medical chart to an electronic health record system. And what we need is a system which, from the ground up, has fundamentally been thought of as a model to coordinate thousands of actors safely and in real time. And the way that you would approach the design of such a system is very different than if you were approaching simply a system which was a replication of a patient chart for a few people to read. And so EHR design is still stuck using a model of healthcare which is no longer applicable today, and it's certainly not prepared for tomorrow. And so if we were to wrap up this section now on design and the purpose of the EHR, we realize that in order to understand the purpose of the EHR, we really need to take a step back and ask what the purpose of the healthcare system is. And the purpose of this venture, which we call healthcare, isn't to store data. It's not to create billings and reports. The purpose is to improve health and to keep the well healthy, to heal the sick, to comfort the dying. And so, therefore, I would propose that the primary purpose of the medical record system is to improve health. Until EHRs are able to do that, they are only achieving their secondary purposes. Billing, reporting, data storage, team communication, legal documentation, these are all secondary functions that help achieve the primary goal, but in of themselves are not the primary purpose of healthcare. We don't establish healthcare systems because we want to store data and generate reports. We establish healthcare systems because we want to deliver healthcare. And so we must always remain focused on the primary purpose of healthcare, not let a secondary means replace the primary purpose, which is what I think in general has happened in the sector of electronic healthcare records to date. Well, now that we've set a very ambitious and lofty goal of the purpose of an EHR, why don't we now look at the state of design in EHRs today? And when we want to evaluate the state of design in EHRs today, we are really asking ourselves, what is the impact of an EHR on the healthcare system? And we'll start with the theme of physician dissatisfaction. And for many years, we have known that things are not going well. However, a lot of these conversations have really been confined to the doctor's lounge or medical conferences, where a favorite topic of conversation is the frustration that physicians have with their information technology systems. Clinicians love to tell each other stories of how the user interface of the EHR system is slow to use, outdated, reduces their ability to see patients. They voice how these systems have dangerous user interfaces that cause patient errors. They complain how the cost to purchase these systems is sky high and wonder if those funds could have been used to achieve better returns in some other part of healthcare. And most frustrating, the one thing that people expect from digital systems, the ability to share information between hospitals, between doctors, and with your patients, remains often impossible and highly fragmented. And so all these grievances are compounded by the fact that physicians feel nobody in their institution's administration understands them, nor wants to work with them to make the systems better. And we've seen numerous articles being published discussing issues with EHRs. This one from 2013 talks about the burden of having to have 4,000 clicks for one emergency room physician in the course of their shift. Anyone who does something 4,000 times will certainly be prone to error. We see the connection between physician burnout and EHRs, and this too has been known for a number of years. Multiple studies have ranked the EHRs the number one source of frustration in the workplace, such as a 2013 RAND study. And we've had large books such as The Digital Doctor, Hope, Hype, and Harm in the Dawn of Medicine's Computer Age by Dr. Bob Watcher, or books such as Mistreated, Why We Think We're Getting Good Health Care and Why We're Usually Wrong by Dr. Robert Pearl. And these have also helped shine a lens into the system and the dysfunction. And it's important to realize that this dissatisfaction with EHRs is not limited to America. It's a global issue. Here's a study of physicians in Finland, a country with wide EHR implementation, and we see that they report low physician satisfaction. Another study here also looking at EHR systems around the world demonstrates additionally, again, concerns about the accessibility, reliability, and the EMR utility of these systems. And so if we wanted to maybe quantify all of this subjective physician opinion about EHRs, one of the best places to look, I think, is the Medscape EHR reports. Their most recent one here is in 2016, and what it does is survey 15,000 physicians from 25 medical specialties across America. And this is, again, subjective data, but I think it's definitely worth looking into if we want to get an understanding of the subjective experience. Well, what we know, of course, is that The most widely used systems in this survey are Epic, Cerner, Meditech, and Allscripts. eClinical works as well. And when you ask what the top-rated EHR is, we see that the one that comes out on top is actually Veteran Affairs CPRS system. And so yes, this is a homegrown government-funded system which is ranked by physicians as the top-rated. And as Medscape observes, it's also interesting to note that all the top 5 rated EHRs in 2016, in blue here, performed worse in satisfaction than they were 2 years previously in the survey in 2014. If we look at what the top-rated EHR by hospital use systems is, we see again that the VA system comes out on top. If we look at the top-rated EHR by independent practice, it's Epic. If we look at the top-rated EHR for ease of use, we see amazing charts in Practice Fusion, having spots 1 and 2 for both ease of use as well as satisfaction, and then the VA system coming out in number 3. If we look at satisfaction for vendor support, Bedent ranks the number 1. If we look at rankings for connectivity, the highest rating again is for VA and CPRS, and connectivity here is being defined as interfacing with diagnostic services, practice management, reference, and hospital labs, and supporting referrals. If we look at the top rankings for the usefulness as a clinical tool, an important question, we see that the one that comes out on top here, again, is the VA system. And this is a very interesting question. When you actually go and ask physicians, what is the effect of an EHR on your practice, specifically in the areas of documentation, patient service, clinical operations, and bill collections, the overall summary is that maybe 30% of people suggest that it's improved their practice. The figure we're looking at here on the right is a chart which was rebuilt by Dr. Joel Solanchio. And he took the data here from the initial Medscape 2016 report and summarized the no change and got worse columns. And so as we see in the more dramatic view here on the right, the overall impression is that EHRs did not improve their practice. If we ask the question another way, as Medscape did, what's the effect of the EHR on patient encounters, whether you're looking at face-to-face time with patients, managing treatment plans, the ability to respond to patient issues, and the number of patients that a physician can see, it's all either essentially had no change or gotten worse. The number of clinicians which say that an EHR has improved their face-to-face time with patients is 11%. Even something such as the management of treatment plans, which should certainly be better on an EHR system, only 38% agree with that statement. And then, of course, most prominent here under number of patients that a physician can see, the number has gotten worse through the introduction of the EHR system. Satisfaction with EHR vendor is surprisingly neutral to low at best. And when you ask people, regardless of what their age is, whether they're comfortable using an EHR, all groups remarkably respond approximately the same. And when you look at the effect of the EHR on the workflow broken down by the age of the physician, you see that all physicians, regardless of age, agree that it has slowed down their workflow. With the most prominent being, of course, with 71% of elderly physicians agreeing most prominently with these statements. I think it's a bit disconcerting when you look at the data around what physicians recommend on how to get around the negative patient experience with using an EHR, that you should apologize in advance to your patient. You should try to learn to use touch typing. I think that this is all indicative of a system which has been not brought together well into a clinical workflow and is causing a fair bit of disruption. If we ask clinicians, though, despite all the above data, do you want to keep your EHR? We see the conclusion is 81% of people want to keep their EHR as opposed to switch the system. And so again, I highly recommend you go back to the original Medscape report and look through all the slides yourself. But right now what we'll do is we're going to shift and look into some more objective data now, specifically around efficiency and the safety issues of these systems. I think one of the best people studying this right now is Dr. Raj Ratwani, who has been working with his team and published 2 very good papers in the last year. The first here is on the usability of an EHR system, and they studied 2 large sites using Epic and 2 large sites using Cerner. And both of these sites had been using these systems for over 2 years. They had their participants in the study enter the order Tylenol 500 milligrams PO 4 to 6 hours and into the medical record system. They found on average this took about 1 minute to enter this 7 words into the system, as well as needed somewhere between 14 and 62 clicks, and resulted in an error rate between 8 and 30%, with the errors being either the wrong dose, frequency, route, or rate. When they had participants enter this order, prednisone taper, 60 milligrams reduced by 10 milligrams every 2 days for 12 days, it took 3 minutes to enter into the system, somewhere between 20 and 40 clicks, and resulted in an error 17 to 50% of the time, of which the error was the wrong dose. And a third example from their study of asking participants to order an X-ray of the left elbow, wrist, and forearm only took between 20 and 64 seconds and only took between 8 to 31 clicks, but resulted in an error of 16 to 36% of the time, being that the wrong side of the X-ray was ordered or they forgot to order on the right part of the body. And so these are very common orders which Dr. Ratwani has studied in his paper here. And it's important to realize that if you had to put in more complicated orders or more rare orders, it's probably only going to take longer, and it's probably only going to have a higher rate of mistake associated with it. Another example of a paper from this last year, just November 2018, was looking at the EHR usability and safety in pediatric settings. And so in this study, they looked at 3 large clinical sites. 2 were using the Epic system and 1 was using the Cerner system. And they reviewed a total of 9,000 patient safety reports around medications between 2012 and 2017. What they found was 36% of the safety reports were attributed to usability issues, of which 19% of those probably or may have resulted in patient harm. And so if you look online at the paper and the graphics, you can look more detail regarding the type of troubles with the visual display, such as the wrong information being displayed, hard to find and confusing information display, suboptimal interface between applications. And you can also see then the breakdown on how these different types of errors or these different types of usability problems influence the different types of errors, of which the most common errors were either the wrong dose or the wrong time. Now that we've looked at a little bit of objective data, we could also see that there's, of course, a large amount of satire around the EHR problem, which has been built up. Gomer Blog, which is really the leading medical satire website, has discussed for years how bad EHR systems are. And this article of theirs, they discuss how the hospital wants to go back to the more efficient paper system. This Gomer Blog study ranked the EHRs by their administration's opinion of them versus the clinicians. And we, of course, have ZDog MD, a former Stanford internist, who routinely discusses the failings of modern EHR systems. And this particular song, EHR State of Mind, has almost 1 million views now. And again, this is all just discussing the failing of the EHR system in America. Even here, Dr. Donald Trump has been discussing the huge problems with the EHR system and potential solutions. So we've discussed how the frustration with the medical record system has moved from the doctor's lounge through news articles, through research publications, and in many ways people have felt that the public have not realized the significant issue this is. But I think things have changed in 2018. A few examples. Just in January 2019, we saw that Harvard called physician burnout a public health crisis, and this report lays a large amount of the blame on the growth in poorly designed digital health records, and quality metrics has required that physicians spend more and more time on tasks that don't directly benefit patients, contributing to an epidemic of physician burnout. We also saw just in the last 4 months 2 really important papers published. One was in the New Yorker by Atul Gawande. It's titled Why Doctors Hate Their Computers. And the second is in Fortune, just this March, by Erica Fry and Fred Schultz. And they titled their article Death by 1,000 Clicks, Where Electronic Health Records Went Wrong. And so I think these 2 titles themselves summarize the state of EHR design today. I highly recommend you read both articles. Each one is over 9,000 words long. If you're interested, a Tools article is available in audio on the New Yorker website, and the Fortune article does have some short videos you can watch if you don't like to read. A Tools article, I think, is really good in that it accurately describes the frustration among physicians with the introduction of information technology into healthcare. It highlights the tension created between physicians, patients, and machines. It accurately discusses the increased burden of work in that health IT is put upon clinicians. The problem I have, though, with this article is I think it lumps together the different causes of information technology problems into just this general category of technology. And then Tool juxtaposes technology against humanity and says that technology might be a problem. I think he's not nuanced enough. He doesn't separate out the issues with EHR technology into the different groups responsible for it. For instance, the problems with health IT that are the result of objectively bad software, the problems with health IT which are from committees and administrations which have implemented it poorly, and the results of bad health IT, which are the result of maybe chief medical informatics officers who never fully campaigned sufficiently to make these systems better. Read the full article yourself. It's very good, though. Or at least it's very good at describing a clinician's frustration with the system. I don't think it's very good at explaining what's gone wrong. Or properly diagnosing that. The second article, Death by 1,000 Clicks, here in Fortune, as well as through Kaiser Health News, discusses a lot more of the backstory to this EHR problem. They go through what has been documented by other people, such as in Bob Watcher's book, the story of how the 2008 recession caused the government to look for shovel-ready projects which they could inject capital to stimulate the economy. And it just turned out that the digitization of paper records in America was one of these shovel-ready projects. And so over the course of the next decade, over $36 billion would be injected into the installation of information health systems. And so the issue was that prior to government grants, people were not flocking to install EHR systems based on the incredible quality of these systems. But when free money became available, it dramatically grew the size of this industry, which had a subpar product, without actually growing the quality of the product. And so combining with this meaningful use regulation, additional sloppy software was designed and rushed into production and shipped. And so, again, highly recommend both articles as well as the Harvard report. Well, why don't we just change gears now and try to identify, what 5 reasons might exist that the EHR design is so bad. And this is by no means an exhaustive list. There's certainly more. Feel free to contact me. I'd love to add to this list. But I think, a lot of the blame, let's just start with the EHR vendors who have created bad software design with misaligned market incentives. The user interface design of most EHR systems is objectively outdated and bad, according just to contemporary 2019 user interface standards. Most systems use a design language that appeared to have been written sometime in the 1990s, and it's not been updated since. And it's always easier for these companies to add more buttons, more tabs, more windows to expand functionality of the systems, but this results in a software which is a maze to navigate, and it's neither simple, intuitive, or efficient. And why have these user interfaces not been upgraded? Well, it's probably pretty complicated. It's likely a combination of the backends of these systems were written on server systems from decades ago, and this must make updating the front-end client side much more difficult. There's also a lot of misaligned market competition around EHRs where vendors compete on the size of their market share to solicit new sales, not really on the direct quality of their product offering. And so just as nobody got fired for buying IBM, no CMIO or hospital administration is going to be fired for buying a legacy EHR vendor. The second reason for why EHR design is so bad has to do with the administrations who saw the EHR as a means to capture increased billing in their healthcare system. And this resulted in higher profits and higher returns. I mean, if this was the purpose of the healthcare system and the EHR, in many ways it's achieved its goal. These EHRs are better at increasing billings. And so if that's the primary purpose of why healthcare and why EHRs exist, full marks. I also lump into this category of administration, though, federal administrators who had good intentions through meaningful use regulations, but ended up with unanticipated adverse consequences in workflow changes. We also have to look at the committees which implement these EHR systems. Certainly they're to blame. Each committee adds its own mandatory fields when it takes paper workflows and makes them digital, and they add new alerts. And when you put together all the new alerts and all the new mandatory fields from all these committees, you end up with a workflow which is essentially unusable in its digital form. I've actually previously written about this in another article titled 5 Ways to Improve Required Fields in the EHR. And the third group that I also don't let off the hook is Chief Medical Informatics Officers, CMIOs. And although some work hard on behalf of clinicians to improve the EHR, my observation is that in order to become a CMIO, you really need to drink the corporate EHR Kool-Aid. Often the CMIO is the champion of the medical record system on behalf of the administration and on behalf of the EHR vendor. And they push physicians to use the system because it's good enough, rather than working with clinicians to demand the administration, the EHR vendors, to strive higher and to make systems which are better. The third reason that EHRs are so bad has to do with the EHR gag clause, and this is an embarrassment of the healthcare sector. A critical ability to be able to have innovation is the ability to share and learn. And this gag clause essentially makes that very difficult. Many EHR contracts make it illegal to either speak poorly about your system or to post screenshots of the EHR, even for academic purposes. If you want to publish a screenshot for an academic purpose, you have to have explicit written permission from the vendor. And this makes creating this presentation on EHR design so difficult. Online, there just aren't many screenshots of EHR user interfaces. I can't demonstrate how many clicks it takes on most systems to order a simple medication. I can't show you actually how slow and fragmented these interfaces are to navigate and consume data. I can't show you how the data density on these screens is inappropriately low, or how EHR vendors have been known to threaten legal actions against physicians who have actually posted these screenshots to try to tell others. And this is problematic for two reasons: innovation and safety. On the innovation front, people become an expert in something by studying and building on the previous generation. Artists listen to other artists, Musicians listen to other musicians. Architects study other architects. Scientists study other scientists. Chess masters study game master from master gameplay. Business leaders review case studies from other businesses. And the inability to do this type of historical analysis on EHR user interface design makes innovation slow, and which gets to the second bigger problem of safety. And Dr. Jerome Carter of EHR Science has this important quotation. He says, "Currently, we lack any sense of the best design choices for any aspect of clinical systems. There is no manual to consult for the ideal user interface for neonatal nurses, or frequency distribution of errors likely to occur with EHR problem lists, or a guide for drug interaction algorithms. Just about everything known about the complex clinical systems is proprietary. But intellectual property claims are not antagonistic to engineering principles. Aerospace holds no threat to Boeing." And this is really critical, that we need to move away from thinking that the reporting of EHR safety errors, that the reporting of EHR usability problems is a threat against a company, and realize that we have mandatory and standardized and national level reporting in other industries such as aerospace or transport. And this has been an improvement to the industry and not something which has hampered it. The fourth reason why EHR design is so bad has to do with the separation of health delivery and of health informatics development. When you look at the clinical systems that have had very high user satisfaction ratings, such as Veterans Affairs, VISTA, Indiana University's Regan Street Institute Medical Record Gopher system, the Brigham and Women's Hospital BIC system, one of the magic ingredients was the merger under a single roof of healthcare system delivery and health information technology development. And over the last decade, healthcare delivery and healthcare technology development have become separated with the wider adoption of commercial off-the-shelf systems. And I believe this makes innovating in either the healthcare delivery side or the health informatics side much more difficult. In business, you should not outsource a critical competitive advantage of your organization. And in the case of healthcare, this is the very thing that every healthcare organization has done. And last, number 5, the growing gap between consumer technology and enterprise technology is part of the reason why EHR's design appears so bad. For the first 3/4 of the 20th century, business and enterprise systems were always superior to technologies for consumers at home. Consider the very name, IBM, its original name, International Business Machines. It was the business which held superior technology for many decades. But eventually, with widespread adoption of personal computers and more significant mobile technologies, such as cellular phones and the internet, consumers have actually begun to have more advanced technologies earlier than their workplace. And so this means that the gap between the technology that people have outside of work versus the technologies they have at work is growing. And this creates a disparity in the impression that their organization is behind. Now, why is the enterprise technology sector a laggard in this area compared to consumer? I think there are two reasons why. The first has to do with the fact that design follows product turnover. You have a much higher turnover of software and hardware in the area of mobile. This is changing every few days, weeks, months, and years. This is in comparison then, let's say, to desktop hardware, desktop software, which had slower turnover cycles, perhaps measured in several years. And as a result, I actually think that if you look at the advancements we've seen in mobile user interface design in the last decade compared to desktop user interface design over the last several decades, the rate of progress and innovation in mobile is much faster. And then, of course, the third example would be enterprise technology and hardware and software, which is turned over in a product cycle measured in decades. And it is this slow turnover of EHR systems that contributes to their lack of innovation, which is reflected in their poor design. The second concept which I would like to address is how design follows technology. This is actually a favorite theme of mine and it deserves its own article. But in short, new design follows new technology. And you can apply this to any field of design. So for instance, if you look at architecture, the reason we have modern buildings with extreme curves and extreme shapes is that we just now have the technology. We have the manufacturing processes and the computer software capable of this extreme engineering work. And so the same is with interface design and human interaction design. The design we can create is a reflection of the technology available. And because consumer products are much quicker to adapt new technologies, as a result, their design language is able to be updated much quicker than enterprise software that is slower to adapt the new technologies. Well, those are 5 areas on why EHR design is definitely lacking. Why don't we now consider 5 themes for EHR design to consider if you were designing an EHR system today or tomorrow and wanted to try to really make a good system. And again, of course, this is not an exhaustive list. The first is the EHR system should improve efficiency. This is, fundamental, I think, to all EHR implementations, but it's very hard to measure. What do you mean by efficiency? For instance, it can mean a lot of things. How quickly can new users use the system safely? Or are you measuring how quickly can an expert operator use the system to input and retrieve data? For instance, the Bloomberg Trading Terminal is famously efficient for users who are experts of the system because it can be operated almost using a keyboard entirely. But for novice users who have to go through the learning curve, it's very inefficient to learn. And so the question is, what type of efficiency are you measuring in this case? Is it a net efficiency? And so efficiency is important but hard to quantify. The second has to do with safety. As discussed, the reversal of the EHR gag clauses is critical to permitting research and learning and identifying safety issues. And EHR systems really need to be tested with best practices disseminated and when objective answers about EHR safety are arrived at. The EHR system should improve how clinicians think. It's underappreciated the impact that EHRs have on clinical care. The order that the clinicians consume medical information, the order that the information is presented on the screen, the way that that information is divided across different tabs and windows, all influences the ability of a clinician to think and reason. And the way that clinicians enter information into the system, whether it's through narrative-free text versus checkboxes, all this deeply affects the ability of a physician to reason and to understand a case and to provide empathetic care. I think this is generally understudied area of the EHR system, and it's probably one of the highest areas of concern for very senior clinicians who look at the way which newer graduates who have grown up only using EHR systems think and reason clinically. The fourth theme is that an EHR should improve patient care. This is obviously, maybe I should actually rank this up to number 1. It's kind of the most important part of this whole venture. But what this means, I think, is that the EHR system shouldn't only just provide some alerts to the user, but it also needs to help, in the long run, actually assist with diagnosis, with disease management, with team care coordination, with understanding the variation in quality of care and helping us reduce medical error. And fifth, but certainly not last, an EHR should improve user satisfaction. Now, some may disagree. Some may say, well, if you have a system which is efficient and safe and improves patient care, who cares how satisfied your users are in using the system? And I think that user satisfaction is very important. For instance, if users perceive their workspace or their workplace is giving them outdated technologies, that employees are being given fax machines, roll and scroll DOS-based systems, a lack of ability to email patients, the employees will assume their employer does not care about providing high quality care. And so in turn, I think that if they assume the employer doesn't care about high quality care, that this will influence the way that people actually perform their jobs day to day. And of course, the corollary, if people perceive that their employer is trying to give them the best tools available, I think they will rise to the occasion and actually perform their jobs better. Let's look at some considerations for EHR design. And again, this list is not extensive, but one, who is using the EHR system? Are you building it for a doctor, for a nurse, a pharmacist, a patient? The user role is going to dramatically vary. Number two, what device is this EHR designed to run on? A mobile versus a dual large screen monitors? How does it work offline? How does the clinical decision support work if you're in offline mode versus online mode? How is the system planned to adapt to anticipated future user interfaces such as heads-up displays or augmented reality? Number three, how do people interact with the EHR? Is it by a mouse, by a keyboard, by a voice, by a medical scribe? Are you using a digital scribe, such as one of these newer machine learning tools which listens to the conversation between patient and physician and then automatically captures the relevant, important information? Technology which is very early in development, but is definitely being put forward as a means forward. Each of these methods of interaction influence clinical reasoning, influence efficiency, has its benefits and drawbacks, and needs consideration. The fourth area is what is being shown on the EHR screen. Are we again just replicating a paper chart in digital form? If that's the answer, you've probably gone down the wrong route. A recurring theme of Edward Tuffy is the importance of data density and helping understand information. And as we see in contemporary EHRs that have data spread sparsely across multiple screens, this influences negatively efficiency, clinical reasoning, and safety. And as EHR systems assimilate more and more patient data, it'll be important that what they show on the screen is done in a manner which is clear in order to highlight the most important information. And of course, the last and the fifth and one of the greatest considerations is, will this break or will this build a better workflow? An example is of a system which was working really well on paper, which then kind of got broken down when they moved to an EHR system, is the concept of an EHR inbox. Most EHRs have this inbox where physicians receive results. So the lab results might come into the inbox. So the clinician then has to open the inbox, then open the lab results. And if it's a modern system, sometimes it will graph within the inbox older lab results. But other systems, you have to then open the patient chart, go to the patient's lab result panel, and then trend them in that part of the chart yourself. And depending on what type of software you're using, a lot of EHRs actually can't trend more than one variable, which is crazy. But the question still might remain, why did I receive this result on this patient? And so the clinician then might have to open the notes section, scroll through to find their note, read their old note, understand what the patient's condition was and why they ordered the medication. And then they might need to look at other information, such as the patient's surgical history or medical history. They might need to look at other information, such as the changes in that patient's medications, and then decide whether the labs that they've looked at are normal, abnormal, and if so, need any change to the patient's medications. This workflow is hectic and crazy. And this is in contrast to how the workflow was before the EHR came. Before, an example of this hematology clinic that I know, the clinician would receive new lab results and the clinic nurse would automatically graph those results on a paper flow sheet. The paper flow sheet had the patient's name, it had the patient's hematologic condition spelled clearly at the top, and specific lab values were being trended on this flow sheet alongside surgical histories, medication histories, as well as other critical data to that particular hematologic condition. And so in this case, the physician's workflow was to take one look at this flow sheet that would have a new column added when new lab results were received, and they could in an instant know how that lab column compared to the complete context of relevant information for that patient. And so if they needed to change a medication, the physician would write on a sticky note a note to the clinic nurse, and then the clinic nurse would ensure that the prescription was written sufficiently and contact the patient to review further details. And so we went from a very safe and regimented and sequential workflow to a completely hectic workflow because of the introduction of an EHR system. As we wrap up this part 2 on the state of design in EHR systems today, there are certainly areas or groups working on EHR innovation, but I must admit I am not an expert in this. I would like to do significantly more research and meet and understand who is really understanding EHR innovation the best out on a global level. One of the groups which jumps out and comes to mind is MedStart's Health National Center for Human Factors in Healthcare. It's led by Dr. Raj Ratwani, and he's an outspoken advocate of thoughtful and evidence-proven EHR user interface. You'll see this website on the screen here is ehrseewhatwemean.org. And on it, they've been working with the American Medical Associations to start a campaign to lobby Congress to improve EHR safety and to show public safety concerns in EHR systems. So I think following their work is definitely an area of innovation. Another one which comes to mind is Estonia, which has been long landmarked as a digital republic and a leader in wide EHR adoption. Obviously, the size of the country at just over 1 million people makes this type of success much easier, but the 2017 New Yorker article on Estonia's digital republic is a much read. Now, of course, another area is OpenNotes, which is a project which has made a lot of good progress this decade in changing our understanding of the medical record from a tool that clinicians use to something that belongs to the patient. And so multiple OpenNotes studies have shown the benefits of providing patients full access to medical records, and this knowledge is, I think, deeply affecting the way that new HR systems are built. And of course, OpenMRS, I am full disclosure, in complete conflicts of interest with this side. I work closely with OpenMRS. I think if you wait over the next coming year, there's going to be a lot of very exciting news regarding their medical record system and some areas of EHR innovation. Let's move on to the third part. Part 3. This is the last part of the presentation where we're going to think about the future of EHR design. And if we go all the way back to the start of the presentation, we describe that design is how something works. And so the question then will be, how will healthcare work in the future? And so in order to understand that, we need to look at the challenges that we're faced as well as the opportunities. And by understanding those, we can then understand what the future of the EHR roles in that will be. And so when we look at the challenges of healthcare, I think we should not focus specifically on Canada or the United States, but we should look at healthcare challenges from a global level, from the perspective of all 7 and 8 billion people. We see, of course, the obvious, the rising cost of healthcare, and the significant concern that the annual increase in cost per year increases the growth in GDP. So this is mathematically an impossible long-term trajectory. We see that there's a huge challenge with the differential ability to pay, where most countries in the world do not have at all the ability to spend per capita on healthcare what is being spent in North America and Europe. We have the challenge of reduced efficiency of the healthcare sector. This is one of my most favorite charts from McKinsey here, where what they're showing is a graph of different sectors and the productivity improvement that's occurred since 1990 to 2007. But if you go to the very bottom of the list, you see that only a few sectors did not become more productive, and one of the worst culprits was healthcare, which actually lost productivity with the introduction of the information technology revolution. this is counterintuitive because healthcare should be an information industry, and the fact that the introduction of information technology actually didn't work is a story which we're telling today. And in addition to this, healthcare with the reduced inefficiency has had to hire more personnel, unlike all the other sectors, which means that the costs, of course, continue to rise. We have huge variation in the quality of care, and I use the euphemism variation in quality of care to describe the fact that medical error is rampant in healthcare. A BMJ analysis, which was admittedly contentiously discussed, suggested that medical error was the third leading cause of death in the United States. I'm actually one of the few people which strongly agrees with these types of papers. I think that medical error is significantly underreported based on my observations as a medical student and resident and fellow. And we also know that medical error is a huge issue just based on subjective experience. For instance, when a family member goes to the doctor, especially a family member of a clinician, you always wonder, well, what doctor did they go to? What hospital did they go to? Who is the ER doctor? Who is on ICU at that evening? Which surgeon is planning the operation? We ask these questions because we know that the answer to them may have significant differences in the outcome of care delivered. And so long as these types of questions are a concern, we have too much variation in the quality of care. And that's just variation within a single system. That's not variation between countries and on a global level, which is a huge disparity in of itself. When you look at the challenge of the shortage of healthcare personnel, this is a huge issue for most of the world where you have very low physician densities. This WHO paper suggesting 13 million people will be short in the healthcare workforce in the coming decades. And of course, we have huge burden of disease, which is a challenge for healthcare. We've known for many years that tropical and contagious communicable diseases such as tuberculosis are rampant in most parts of the world. But one of the things which I think less people appreciate is the huge rise in non-communicable diseases, things such as hypertension, stroke, diabetes, which is occurring even in the low and low middle income countries. And so when you look, for instance, at something such as the mean systolic blood pressure among men on a global level, you actually see that the levels of hypertension are highest in most of the world outside of North America and Europe. And so this is, I think, something that a lot of people find a bit counterintuitive and shocking from this WHO data, that although, for instance, with this example with the incidence of diabetes among women, we think this is a huge problem in North America and Europe, but when you look at the data on a global level, you'll see that actually North America and Europe barely register in comparison to many, many other countries. And so all these challenges we've discussed are amplified by the change in demographics we're going to see over the next century. We know, of course, that Europe and North America, these lines at the bottom are essentially plateaued out in terms of total populations. We see that Asia has almost peaked. We're currently here, and right before 2050, it's anticipated that Asia will peak in its demographics. And then we see the red line here of Africa, and how over the course of our careers in the next 50 years, that their population is going to double and triple in size. And so with this, it presents tremendous opportunity, but it means that we need to really make sure that early childhood nutrition and early childhood health and education is as optimal as possible in order to set as many countries up to succeed as possible when we look at the evolution of the world over the next century. Well, these are certainly a lot of challenges, but technology presents with it opportunities. And what I would like to do is discuss 6. The first is that the rate of the adoption of technology is increasing faster with each decade. Over the last 100 years here, you can see that the telephone took many years to be adopted to 100% in the US, but with each passing decade and each new technology, the time that it takes to get high adoption of that technology increases. The lines become almost vertical from the time from implementation to wide adoption. We see the same with widespread cellular connectivity, with high global penetration, according to this study, estimating 93%. And you can look at the data on this graph as well, showing the total number of adults in the world and the total number of mobile users, something which just a few decades ago was essentially zero and has now dramatically, almost entirely reached 100%. We have the opportunity of cheap computational power, something which has been going on for over a century with Moore's law, and we've reached a place in the computational power combined with new analysis techniques where we have the opportunities of machine learning and the ability to potentially study large amounts of data and to derive actionable predictions from this data. In addition, we have more sensors, which are just going to flood the global market in the next 5 to 10 years, which will mean with it more data, which potentially means the ability to understand disease surveillance and diagnosis in new ways, which is, of course, paired very closely with the opportunity of new genomic insights. For much of the last decade, the cost to sequence a genome has been prohibitive, whereas now it is almost inconsequential. And this will bring with it significant new insights in medical diagnosis and investigation. And so with each of these technologies, it's very important to think about their S-curve. And so this is a slide from Benedict Evans at Anderson Horowitz. And at the bottom part of the S-curve, the bottom flat part, and this was the same with any exponential technology, you find that people don't adopt it. It has a slow rise until it enters the market and then starts to take off and explode. Then you get widespread adoption of that technology, and then eventually that technology begins to flatten out as far as its performance and its user adoption. But then a new technology comes along which undergoes a similar S-curve. So one of the questions we must ask ourselves, is this the time for electronic health records to help rebuild healthcare systems? Are we at the right place with these S-curves on different technologies such as connectivity, computational power, that we can now make a significant leap forward? For much of the last century, we've been trying to build better data systems in healthcare, whether it's pneumatic tube systems of the early 1900s or clinical charts in the 1960s, or if you read the early papers from the pioneers of electronic health record systems of the 1960s, you see that the aspirations of these systems is the same aspirations we have today, that electronic medical record systems will aid in medical diagnosis, in laboratory analysis, in patient monitoring, in hospital communication, and in hospital and facility service utilization. We've known as well for over half a century about the benefits of EHR systems, such as Clem McDonald's 1976 New England Journal of Medicine publication on protocol-based computer reminders, the quality of care and the non-perfectibility of man, showing the beneficial effects of such systems. But for whatever reason it is, whether bureaucratic, financial, or technical, the vision of an EHR systems from over half a century ago has not yet come to fruition. But is this the time which might be opportune? When we consider these challenges that we're faced in global healthcare, rising costs, inability to pay, reduced efficiency, shortage of healthcare personnel, high variation in quality of care, rising burden of disease, growing demographics, when we look at these challenges against the opportunities that technology presents, widespread connectivity, computational power, machine learning, better algorithms, do we now finally have the right time to finally achieve what we had hoped to set out to do? And so is this the time where, because of the challenges we face on a global healthcare perspective, we know that we need to develop new methods of healthcare system delivery? We can't scale the existing models of healthcare delivery to 5 billion people who don't have adequate care. And will this new technology allow us to perform task shifting in a way we've never done before, to move work which was previously only done by physicians to other care providers. And in addition to moving work to other care providers, are we able to build a tool, build an electronic healthcare record which is able to assist in significant ways in routine diagnosis and routine management of routine patient conditions, meaning that you could take a healthcare worker with a few years of professional training and combine them with this powerful tool that actually assists in diagnosis and management and elevate their skill set to a level much, much higher than their training permits. Is this the way which we'll be able to create a scalable model of healthcare and to scale this to the 5 billion which need it? And Peter Diamandis often talks about the 6 Ds of an exponential technology. And we need to consider what happens if we digitize clinical decision support. And so when we think about the 6 Ds on how a technology first is digitized and then it's deceptive, people don't know it's being used, and then all of a sudden the exponential technology hits the kick of the curve and becomes disruptive. And as it disrupts because it's a digital technology and therefore it doesn't need it disrupts by demonetization as well as through dematerialization because it's able to penetrate on a global level using digital means. And so if you could make the cost of healthcare the same as the cost of a Google search, which is essentially free, if you can make the cost of the decision support, for instance, of knowing if someone has diabetes and what the next step of their diabetes care should be, if you could digitize that, I think this would fundamentally transform the way we think about healthcare. And so really the electronic healthcare record is the future of medicine, or the future of medicine is the electronic healthcare record. The two are so tightly coupled, as we've been talking about for the last hour, the design of the healthcare system and the design of the electronic healthcare record. And so you'll experience many different design issues as we approach the future. And if you want to read through them in more detail, feel free to open the actual blog post where they're described there. But I think the most interesting one to consider is the same question with driverless cars. With driverless cars, we're needing to understand how we create a design language where when do we move control from the driver to the car, and how does the car then know when it's uncertainty about the conditions are too low or when the situation is too dangerous, and how does it then alert the driver to retake control? And these same questions we need to understand in digital systems. When does the EHR take control in the coordination of a patient's care? And when does it surface concerns? And how does it surface concerns to clinicians in order to allow the clinicians to weigh in and then take control? And so many different design questions will emerge, which we don't have an answer to yet. And again, you can read those on the blog post. Well, that's it. We've looked at 3 parts now. We started, if you're still reading or listening, I'm very impressed. This is a very long piece. And I hope you agree now, though, that an EHR is not a digital filing cabinet. It really needs to be understood more as the neural network of healthcare. Just to summarize briefly here in about a minute, today we looked at 3 things. First, we looked at design, and we underscored how design is how something works, and the importance of design when we're evaluating and the importance of understanding an item's purpose in understanding its design. And in the case of an EHR, we said that its purpose was to provide healthcare. And we classified all the other functions that a system may do, such as billing, reporting, legal documentation, as secondary means to achieving the primary function. And so we've created a dichotomy here, which is, I think, very important. The second is we looked at the design of EHR systems today, starting with subjective frustrations of the clinicians, then looking at objective data showing the inefficiencies and safety issues around these systems, and then some articles which have gone quite public discussing the state of EHR systems. We've looked at some causes of bad design, some areas for better design, and some groups working on EHR innovation. And last, we considered the future of design in EHRs. by starting at looking at the challenges that healthcare presents to us on a global level and the technologies and opportunities associated with it. And I think it is that intersection of the challenges we face and the technologies we have where the EHR can really shine. And perhaps we now live in the right time to be able to achieve the dream which we set out to as an informatics community many decades ago. And so hopefully the challenges which we have will push forward the EHR to become not just a chart, but an actual system which coordinates complex healthcare delivery and the digital data which we have in this system will be able to play a significant role in routine diagnosis and care management, allowing us to address these challenges in quality of care, diagnosis, and scaling healthcare to the 5 billion which need it. Well, I would love to hear your thoughts and criticisms. You can contact me on the website, gregoryschmidt.ca. Thank you for your attention and look forward to your feedback.